Gout. Gout is a metabolic disorder. However, because the clinical presentation closely resembles arthritis, gout is also classified as a form of crystal-induced arthritis. The biological precursor to gout is elevated serum uric acid levels, that is hyperuricemia. Here is the picture of a toe of feet having gout, and it is characterized by swollen and inflamed joint along with uric acid crystal deposition. Characteristics: occurs in approximately 1% of the population with male to female ratio of 20 to 1. Characterized by pathological reaction to monosodium urate monohydrate crystals by the joint or periarticular tissues. Increases with age and serum uric acid levels, although only a fraction of patients with hyperuricemia will develop gout. Primary gout: overproduction or undersecretion of uric acid, more frequently seen in men and is the commonest cause of inflammatory arthritis in men over 40 years of age. Secondary gout: acquired conditions lead either to overproduction, myeloproliferative disorders, or undersecretion of uric acid, that is renal failure. Drugs such as aspirin and diuretics can precipitate acute attacks. Clinical features: characterized by severe pain, classically waking the patient from sleep. The joint is swollen and very sensitive to contact. Patient may not even tolerate wearing a sock. Typically affects a single distal joint, with the first metatarsophalangeal joint affected in more than 50% of the cases. Other affected joints include the ankle, knee, midfoot, small joints of the hand, wrist and the elbow. Gouty tophi tend to be a late sign. Here is the radiograph of the foot having gout. Here is the hand having gout. Fever, malaise and confusion can occur, particularly in the elderly and if a large joint is affected. May be difficult to differentiate from sepsis. However, the onset of gout is typically hyperacute. Although polyarticular attacks are rare, acute attack may be followed by the involvement of other joints. This is thought to be secondary to an acute phase response. Attacks tend to become more frequent and involve multiple sites over time. Diagnosis is confirmed by the presence of negatively birefringent crystals in synovial fluid. Radiological features. Radiological features usually not seen until 6 to 12 years after initial attack. In the acute attack, radiographs are often normal or show soft tissue swelling. An effusion may be apparent. Bilateral effusions of the olecranon bursae is pathognomic of gout. Chronic gout is typified by eccentric periarticular punched out erosions, uniform joint space narrowing and changes similar to the osteoarthritis. Calcified tophi are seen around distal phalanges. Chondrocalcinosis, for example menisci, results in secondary osteoarthritis. Bone density tends to be normal unless there is severe joint restriction from pain. Here is the radiograph of gout. Management: aspiration to confirm diagnosis with first presentation, acutely managed with non-steroidal anti-inflammatory drugs and rest. If a tense effusion is present, aspiration steroid injection can be very effective. However, beware of sepsis. Oral colchicine is less well tolerated. Long-term management involves removal of precipitating or aggravating factors. Drug therapy such as allopurinol aims to reduce serum uric acid levels. Thank you.